This is the treatment for a hand, wrist, or forearm injury. Provider 1 will stabilize the injured extremity. If the injury is to the forearm, the provider should hold at the wrist level and at the elbow level. The injury site should be exposed, and provider 2 should assess circulation, motor, and sensory. There are 3 options for splinting this extremity. It will be done with a rigid splint. There is a short board, which for most patients you will find to be too short. The board must extend beyond the fingertips and beyond the elbow. For the purposes of this video only, do not do this on a real patient. We will show you why the first board is too short. So you will see as they rotate the arm up that the fingertips are on the board, however, the board does not extend below the elbow. The next board that is available is way too long. It creates difficulty in transporting and securing the patient. As you can see, that board extends way beyond where it's needed. If you have a patient that will not work with a short board, a SAM splint is a good alternative. Regardless of what size splint you use, the splinting technique will be the same. The SAM splint should be unrolled and doubled over to help give some additional support. The splint will be laid underneath of the patient's arm. A roll of cling will be placed in the hand to help maintain position of function. Voids should be padded. Most patients will have a slight void underneath of the wrist. The arm should be secured to the splint, again using cling. The cling should start in between the thumb and the hand, making sure that the hand is secured before moving up to the wrist, and then the cling will continue to go to just below the bend in the elbow. If the cling is not long enough to go all the way to the elbow, it is important that a second roll be used so that the board is completely secured to the arm. A cravat should be placed across the patient's chest with the tail to the uninjured side. This will create the sling. This will be a wide sling, so the tail of the sling should point to the injured side. At this point, the patient's arm will be brought into the chest, and the sling will be brought up around. It is acceptable to have a knot in the end of the sling to help hold that in, but again, depending on the angle of the arm, it is not a critical action. The knot should be tied on the uninjured side and padded. Another option, if the arm is lower coming across the chest, is to actually tie the knot down closer to the chest. A swath will again be placed around the patient's across the patient's injured side, coming to the uninjured side to tie. With this one, again, it may go above or below the wrist, depending on the angle and the amount of room that you have. The key is that it secures the patient's arm to the body. You will reassess circulation, motor, and sensory.